Now the topic we are going to discuss is skeletal muscle relaxants. So the name itself indicates they are used in the relaxation of the muscle, or they decrease the muscular tone. So before exactly going into the drugs which are used as skeletal muscle relaxants, let us give a brief of acetylcholine. So acetylcholine is a natural neurotransmitter which is released and which is synthesized and released into the body. So it is acting both as in the parasympathetic nervous system and part of sympathetic nervous system. So in the parasympathetic nervous system, it is acting mostly at the post-ganglionic sites, as well as in the sympathetic nervous system, it is acting mainly, or else it is present mainly in the sweat glands and few of the blood vessels. And whereas in the skeletal muscles, it is present in the skeletal muscles, and it is even present in the CNS, especially at the cortex basal ganglia and spinal cord regions. So these are all the locations of the receptors where the acetylcholine is acting. So here in the parasympathetic nervous system, we have muscarinic and nicotinic receptors, and sympathetic nervous system we have alpha and beta receptors. So acetylcholine will bind to the particular receptors wherever it is acting. So here we have to see NMJ signaling, that is neuromuscular junction signaling. So what is happening exactly at the neuromuscular junction? So between the muscle and the neuron, the junction between there are the NN type of receptors. So here in nicotinic receptors or N type of receptors are two types again, NM and NN. So NN is neuron receptors and NM is muscular receptors. So here the NN type of receptors are present, where acetylcholine will bind to the receptors and exert the action. So here in the skeletal muscle, acetylcholine will bind to the N type of receptors and it leads to the contraction of the skeletal muscle. If we see the muscular contraction, in the muscle we have I band, H zone and I band. So I band is nothing but the lighter portion and A band is nothing but the darker portion. So here the sliding of the myosin, that is the proteins which are present in the muscle, the actin and myosin filaments, they slide over each other in order to produce the contraction, and they move apart in order to produce relaxation. So if we see in the relaxation state, the H zone is longer or broader, and in the contraction state, the H zone is little compressed or narrower. So here the contraction occurs while these proteins slide over each other, and whereby the H zone is reduced, and in the contraction state, we can see the muscles or the proteins are moving apart, filaments are moving apart, and thereby the H zone is broader. What are skeletal muscle relaxants? So these are the drugs which decrease the tone of the muscle, or else they relax the muscle, or they produce the relaxation state of the muscle by, especially they act at the NMJ receptors, thereby they act at the NMJ receptors, and thereby they lead to the blockade of the receptors, and in centrally they act in the cerebrospinal axis. So they act in the cerebrospinal region, and thereby they will reduce the muscular tone, and sometimes they may even cause paralysis of the muscle also. Now let us see the classification of these drugs. So these skeletal muscle relaxants are divided because they are acting both centrally and peripherally. So they are categorized as peripheral skeletal muscle relaxants and central skeletal muscle relaxants. So peripherally acting skeletal muscle relaxants are neuromuscular blocking agents, which are further classified as non-depolarizing and depolarizing. So these neuromuscular blocking agents, the drug which come under the category of non-depolarizing agents are long-acting drugs which are having longer action, that is D-tubocurarine, pancuronium, doxacurium and pipacuronium. And depolarizing drugs include succinylcholine, which is also called suxamethonium, and decamethonium. The other category are directly acting drugs. First category is the non-depolarizing drugs, which are classified as non-depolarizing the first category of drugs are neuromuscular blocking agents, which are non-depolarizing and depolarizing. And the second category is directly acting drugs, that is dantrolene sodium and quinidine. Before going the depolarizing or non-depolarizing agents, they contain the drugs like D-tubocurarine, pancuronium, vecuronium. So these are long-acting drugs. So these long-acting non-depolarizing neuromuscular blocking agents are used as skeletal muscle relaxants, whereas short-acting and ultra-short-acting are not that preferred. So here these tubocurarine, pancuronium, vecuronium, these are all the compounds which are prepared from a poison called as curare. So curare is an arrow poison which is derived or which is extracted from the plants of Chondrodendron tomentosum, and the other one is Strychnus toxifera. So these are the two plants from which the curare compound is derived, and it is derived from a word called as aurare. Aurare means arrow poison. So it is mainly derived by the South American people by the word from the word aurare. And tubocurarine. So tubocurarine is the name given because this arrow, whatever the poison, to the arrow this poison is put and it is blowed through the hollow bamboo stick. So in the hollow bamboo stick this arrow is kept and it is blowed. So that is the reason tube-like structure and curarine. So that is the reason the drug is given as D-tubocurarine. So here we can see in the bamboo stick the arrow poison is kept and it is blowed in order for hunting by the tribal people. So here we can, these are non-depolarizing agents, let us see how the non-depolarizing blockades take place. So if we see in the muscle, there is a synaptic cleft. So in the synaptic cleft, whatever the neurotransmitter which is released from the synaptic vesicles, it directly go and bind to the receptors. When it binds to the receptors, it causes the entry of these, we can say, in the receptors, normally in the receptors, the sodium entry takes place leading to the depolarization of the cell. But here, these neuromuscular blockers, what do they do? They won't allow the entry of the sodium into the channels, leading to the blockade of sodium entry, and thereby there occurs no depolarization. So this is how the non-depolarizing block is taking place. And if we see the depolarization block, here we saw the sodium channel occurs in three different states: closed state, open state and inactivated state. So here the sodium entry will take place, or else we can say the sodium entry will occur into the cell only when it is in the opened state. In the inactive state, the entry occurs, the entry will not occur through the cell, but the exit is not allowed. So here neither the entry nor the exit is allowed, and here in the closed state the channel is not blocked but it is completely closed. So it won't even allow the sodium channels or exit the sodium channels. So here these depolarizing neuromuscular blocking agents, they act or they won't allow the sodium to enter into the plasma membrane, leading to the neuromuscular blockade. Let us see the pharmacological action. So what happens if the skeletal muscles are administered into the body? So in the skeletal muscle, they causes the rapid contraction muscle. They occurs, because of the neuromuscular junction action, because of the action of acetylcholine at the neuromuscular junction, it shows pharmacological actions like a in the skeletal muscle. It causes rapid contraction, especially in the face and neck region, and it causes the contraction in the limbs, trunk, and thereby to the diaphragm, and completely it causes the skeletal muscle contraction. But whereas skeletal muscle relaxants, they relax the skeletal muscle. Histamine release. So histamine is released because of the drugs like D-tubocurarine, mivacurium, atracurium. So these are the drugs which release histamine from the mast cells. Because of the release of the histamine, there occurs some sort of allergic reactions in the body, and these drugs may also produce fall in blood pressure. There occurs flushing and there occurs bronchoconstriction because of the release of histamine. And on CNS, there is no markable effects on CNS if it is given through IV route. So there are no marked effects on central nervous system. And in the GIT, it may cause the paralysis of the ileus. So in the ileum, it may cause paralysis, and it causes paralysis of the ileum after the abdominal operations. on CVS, on central, on cardiovascular system, this D-tubocurarine, it causes significant fall in blood pressure. So D-tubocurarine, once it is administered, it causes fall in blood pressure because of the ganglionic blockade. So it causes blockage of the ganglionic receptors, and histamine is released. So we saw histamine is released by the D-tubocurarine, and it decreases the venous return. So because of the paralysis of the respiratory muscles, the venous return or the deoxygenated blood through the veins is decreased. So because of all these reasons, it occurs the fall in blood pressure. Let us see the pharmacokinetics of these drugs. So these drugs are extremely short acting drugs, and they act for about 5 to 10 minutes, and they are more susceptible to this butyryl cholinesterase and pseudocholinesterase enzyme. So these are the enzymes which are present in the plasma, and it is metabolized through the cholinesterase enzymes which are present in the plasma and liver. And these are the, only a small percentage reaches the neuromuscular junction, because see, these drugs are highly metabolic. So as they are short acting, they can be eliminated out of the body easily, and at the same time they are highly metabolic. They are more susceptible to cholinesterase enzyme. So only small amount reaches to the neuromuscular junction and exert the action. So remaining is metabolized and it is eliminated. And Deboucaine number is one of the parameter which is the characteristic feature of the drug Deboucaine, because it is in the sense Deboucaine number is the number or the percentage of the drug of Deboucaine which is metabolized by the pseudocholinesterase enzyme. So how much percentage of the drug is getting metabolized by the enzyme pseudocholinesterase, that number is called as Deboucaine number. Now let us see the pharmacology of individual drugs. First drug is D-tubocurarine. So D-tubocurarine is a non-depolarizing neuromuscular blocking agent, and it is mainly used, it causes ganglionic blockade, and it releases the histamine, and thereby it causes fall in the blood pressure, leading to the cardiovascular events, and it is having longer duration of action of paralysis. If we see here the action, the mechanism of action of D-tubocurarine, once it is released into the from the synaptic vesicles, or once it is administered, it won't allow the binding of acetylcholine to the sodium channels, and thereby preventing to the depolarization of the cell. The other drug is succinylcholine. Succinylcholine, which is also called as suxamethonium, and this is the mostly used skeletal muscle relaxant for ET intubation. So here for ET intubation, this is the mostly potent, or we can say most widely useful drug, and it has good intubation conditions, and it has quick onset of action. So once it's administered, it shows its actions within 1 to 2 minutes, and it is used as a continuous infusion. So it is not given through IV, it is not given directly administered through IV, it is given as infusion, and it induces rapid and complete paralysis with spontaneous recovery. So once it's administered, it causes complete paralysis, or it paralyzes the skeletal muscle, and thereby even the recovery from the paralysis condition is also fast, that is about 5 minutes. The other drug is pancuronium. So pancuronium is not it does not release histamine at all, and it is not even acting in the ganglionic blockade. So it is acting at the neuromuscular junction. Apart from the ganglion, it does not block the receptors at the ganglion, and it does not even release the histamine also. It mainly acts at the muscarinic receptors which are present in the heart. So here it is causing the relaxation of the cardiac muscles by blocking the activity of acetylcholine at the M2, that is muscarinic 2 receptors, and thereby it releases the noradrenaline, leading to the tachycardia condition. And duration of action of this drug is about 60 to 120 minutes, and it inhibits the enzyme called as and it inhibits the cholinesterase enzyme which is present in the plasma. The other drug is atracurium. So atracurium is more potent when compared to the pancuronium. So it is almost 4 times more potent than pancuronium, and its duration of action is also very short, that is about 20 to 35 minutes. And it is, it is more susceptible to the plasma cholinesterase enzyme, and thereby once it is metabolized by the plasma cholinesterase enzyme, it gets inactivated. So this reaction or the metabolism of this atracurium by cholinesterase enzyme is called as Hoffman degradation. So it is a process of chemical reaction, and it is mostly preferred in the patients with hepatic diseases. It's safer to give for the patients who are with hepatic diseases, and even we can give this to neonates, newborn babies, and even to the elderly patients. So it is safer in all category of the people, and it releases histamine, and thereby it leads to hypotension condition, that is fall in the blood pressure. The other drug is pipacurium. So pipacurium is a drug which is having longer duration of action, and even the onset of action of the drug is also very slow. Once it is administered into the body, it takes some time to show its action. Once it shows its action, the action will stay for a longer period of time, that is for about 50 to 100 minutes. And it is recommended for prolonged surgery. So in prolonged surgery, in long surgery conditions, in order to relax the skeletal muscle tone, this pipacurium is given, and it has very little action on the cardiovascular system. The other drug is vecuronium. So this vecuronium, it is having shorter duration of action, that is for about 30 to 60 minutes, and it is rapidly getting metabolized and rapidly getting distributed. So once it exerts its actions, it gets distributed into the body very rapidly, and at the same time the metabolism will occur very rapidly by the cholinesterase enzymes which are present in the plasma. And recovery is also spontaneous. The recovery from this drug, the skeletal muscle relaxation recovery is also spontaneous. And cardiovascular stability is better, in the sense the cardiovascular actions are stable by this vecuronium drug, and it is most commonly used as skeletal muscle relaxant in surgeries. So in surgical procedures, this is the most commonly used skeletal muscle relaxant. The other drug is doxacurium. So doxacurium is having the rapid onset of action. Once it's administered, within 4 to 8 minutes, it exerts its actions. And but the duration of action of this drug is very long. It is almost 60 to 20 minutes. So the effect of this drug stays for about 1 to 2 hours, and it is suitable for long surgeries. And this also won't have any cardiovascular effects, or it has very low cardiovascular effects. The other drug is mivacurium. So mivacurium is a short-acting drug which is having onset of action of about 2 to 4 minutes, and duration of action is about 12 to 20 minutes. We can say it's very short-acting drug, and it causes the histamine released by this drug. It is having slight histamine release, so it may cause histamine release, but very little amount of histamine is released, and thereby there will be fall in blood pressure will also be low, and thereby it is having minimal or mild cardiovascular effects, and it is hydrolyzed or it is metabolized by the plasma cholinesterase enzyme. But here it causes prolonged paralysis in pseudocholinesterase deficiency. So if the enzyme called as pseudocholinesterase enzyme is not present, or in the deficiency of this enzyme, the this mivacurium action is prolonged, and thereby it may lead to paralysis of the skeletal muscle. The other drug is rocuronium. So rocuronium is a newer compound which is discovered. This is a newer approach of the skeletal muscle relaxant, and it is having the rapid onset of action for about 1 to 2 minutes, and it is having the intermediate duration of action. Neither it is having short, neither it is having longer duration of action, that is about 25 to 40 minutes. And the onset is dose dependent. That is, the onset of action, if it is having the enough dose to produce the skeletal muscle relaxation, it will show rapid onset of action. But if the dose is decreased, then the onset of action will be more. And it's used as an alternative to the succinylcholine. So to the suxamethonium, it is used as an alternative for tracheal intubation. So for tracheal intubation, this is used as an alternative drug for succinylcholine, and it will in order to maintain the skeletal muscle relaxation period, then this drug is the best drug. These are all the drugs which are the non-depolarizing neuromuscular blocking agents, and the drug interactions with these drugs. So these drugs, if we are using thiopental sodium, then the same syringe should not be used for these drugs. So to inject these drugs, because these drugs are reacting with thiopental sodium, and these drugs should not be given with general anesthetics because they cause blockade of the neuromuscular junction, and these are not to be used with anticholinesterase enzymes like neostigmine, because they block the pseudocholinesterase or cholinesterase enzymes, thereby they will prolong the action of these drugs. And they should not be even used with calcium channel blockers like verapamil, and they should not be used with diuretics because it may causes hypokalemia. They may reduce the calcium levels in the kidneys, and thereby they can enhance the blockade. On overdoses, or if they are used in higher doses, they may have toxicity like flushing. They may cause respiratory paralysis. There will be paralysis in the respiratory system, and there will be fall in the blood pressure, and it leads to cardiac arrhythmia. And if the bronchoconstriction stays for longer period of time, it may precipitate asthma. So it may lead to asthmatic conditions, and post-operatively they may cause muscle soreness. So there will be some sort of sores or some sort of blisters occurring in the muscle after surgery. What are the uses of these non-depolarizing skeletal muscle relaxants? So these are used as an adjuvant for general anesthesia. So in the anesthesia, the muscle relaxation is important. So in order to prolong the muscle relaxation, these drugs are used as an adjuvant in general anesthesia, and they are used in assisted ventilation, and they are used to treat even convulsions and trauma also, and thereby they are used in electroconvulsive therapy, and these are used to treat status epilepticus. Now, let us see the directly acting drugs. So, directly acting drugs are dantrolene, whereby they directly act at the receptors at the muscle. So, they won't have any action in the neuromuscular transmission. So, they won't act at the neuromuscular transmissions at all. They directly bind to the muscular receptors, the receptors which are present in the skeletal muscle, and thereby they exert their action. And it is absorbed orally. If we give orally, it is rapidly absorbed, and it penetrates through the brain. So it can penetrate through the brain, and thereby it may cause sedation also. And it is metabolized in the liver, and it is excreted in the kidney. And the T half of this drug is about 8 to 12 hours. So here we can see the mechanism of action. Dantrolene will bind directly to the receptors which are present in the skeletal muscle, and thereby it exerts its skeletal muscle relaxant action, and it prevents the neurotransmitter to bind to the receptors which are present in the skeletal muscle. The dose of this dantrolene is about 25 to 100 mg, and this is recommended to give 4 times a day, and it is used in the treatment of paraplegia, hemiplegia, and cerebral palsy conditions, and even in malignant hyperthermia. So in all these conditions, this dantrolene is given in order to relax the skeletal muscle or the spasms which are caused in the skeletal muscle, and it has fewer adverse effects like sedation. It may cause sedation, and it will have mild headache, muscular weakness. It causes the weakness of the muscle, diarrhea, and it may lead to toxicity of the liver. The other drug is quinine. So quinine is quinine acts by increasing the refractory period. So refractory period is nothing but the state where the relaxation of the muscle, the relaxation of the muscle, or the state of where the muscle is in the relaxed state. So the refractory period will be prolonged or increased by this quinine, and it decreases the excitability of the motor end plates. So in the motor end plates, whatever the nerves are present, whatever the action potential generated at the motor nerve endings, this can be this can be decreased, or the excitement or anxiety which is caused because of the stimulation of this motor nerve endings that can be decreased by the quinine, and it reduces the muscular tone in myotonia congenita. So this is a disorder which is related to the eye, the over contraction of the eye muscles. So that can be reduced by this drug, and it should be taken during the bedtime, especially at the during the bedtime in the dose of about 200 to 300 mg. Now let us see the centrally acting skeletal muscle relaxants. So these are all the peripherally acting skeletal muscle relaxants. So centrally acting skeletal muscle relaxants include the drugs like mefenacin and its derivatives or congeners. The drugs include mefenacin, carcioprodol, and clozoxane, and chlormazazone, and metocarbamol. So these are the drugs which are the analogues of mefenacin, and the benzodiazepine drugs like diazepam, triazolam, midazolam, etc. And the GABA derivatives like baclofen, and the central alpha 2 and agonist like tizanidine. Let us see the first class of drugs are mefenacin and its analogs. So mefenacin, it is the first drug which is discovered as a muscle relaxant. So initially, or in the olden days, this is the first drug which is discovered in order to reduce the muscular tone, and it modulates the reflexes maintaining the muscle tone. So here it mainly acts on the reflexes which are, so here in the brain there are reflexes which are generated in order to control the muscular tone. So it directly acts in the reflexes which are producing or which are maintaining the muscular tone, and it is an irritant if we apply topically. So if we apply the topical preparation of this mefenacin, it causes irritation to the skin. The other drug is carcioprodol. So carcioprodol is analog of mefenacin, and it is a good it is a good or favorable muscle relaxant. Not only relaxing the muscle, it also produces sedative effect, analgesic effect, antipyretic effect, as well as anticholinergic properties. So this drug, as it is a developed form of mefenacin, it is having all these effects, and it is used in musculoskeletal disorders. So if there are any disorders like muscular dystrophy, then this drug is used as drug of choice, and it is even used to relieve the muscular spasm. The other drug is clozoxane. So clozoxane is pharmacologically similar to mefenacin. So as these all are the analogues of mefenacin, they exert the similar pharmacological actions of the mefenacin, and it has longer duration of action, and if we take orally also, it can be, it's better tolerable. It is more preferable orally when compared to other route of administration. The other drug is chlormazazone. So this is a drug, mefenacin analog, which is having both anti-anxiety and hypnotic actions, and it is used for the tension states associated with the increased muscular tone. So if the muscular tone is increased, it may lead to the oxidative stress leading or creating the stress. So this kind of stress or tension or load which is created on the muscular tone, that can be reduced by this drug. The other drug is metocarbamol. So metocarbamol is a good skeletal muscle relaxant. So if we see all the mefenacin analogs, they are having sedative effect. But this drug is having lesser sedative effect when compared to mefenacin analogs, and it is used orally. So it is preferred to give orally in order to reduce the muscle tone in the chronic neurological disorder. So if we see, for example, if we take epilepsy. So epilepsy is caused because of the neuronal abnormality, and thereby there occurs the severe contractions of the skeletal muscle. So in order to reduce the neurological disorders, chronic neurological disorders, then this drug is preferred, and it is given through IV route without producing the why this is given through IV route? Because if it is given even through IV route also, it does not cause any damage to the thrombocytes, as well as it does not cause hemolysis. It does not cause the bursting of the red blood cells. So that is the reason it is safer to give through IV route, and it is used for orthopedic procedures and tetanus. we'll see the benzodiazepine analogs, that is diazepam. So diazepam is a prototype of benzodiazepine. We can say this is the first derived benzodiazepine to exert the action, and from these the structural modifications of diazepam brings the other benzodiazepine drugs, and it is used to reduce the muscular tone, especially in this by the supraspinal rather than the spinal action. So here if we give the diazepam, it exerts its actions by binding to the GABA receptors, and it shows the better action by supraspinal than the spinal action, and it has the sedative effect along with the muscle relaxation effect, and this diazepam is used in the tetanus and spinal injuries, and this diazepam should not be mixed with the analgesics because it may lead to rheumatoid arthritis. Here we can see the mechanism of action. In the GABA receptors, there is benzodiazepine binding site. So this diazepam, it binds to the benzodiazepine binding site. So here in the GABA receptors, it will allow the GABA receptors to open the chloride ion channels, and thereby the entry of the chlorine is taking place into the channel and leading to the skeletal muscle relaxation or producing sedative effect. The other drug is baclofen. So baclofen is a drug which produces muscle weakness. It does not produce muscle weakness like diazepam. So if we use diazepam for longer period of time, it may cause a skeletal muscle weakness. So but this baclofen is such a drug which does not affect the muscle weakness, and it reduces the spasm of the muscle. So if there are any longer spasms, that can be reduced by this drug, and it is effective in stroke. So in stroke, it is used to treat stroke, cerebral related disorders, and rheumatoid spasms, and the Parkinsonism. This drug is used as skeletal muscle relaxant. If we see the mechanism of action of baclofen, here the baclofen, it binds to the GABA receptors as well as it binds to the glutamate receptors which are present in the synapse, and thereby it prevents the neurotransmitter to bind to the receptors, thereby it will reduce the skeletal muscle tone. The other drug is tizanidine. So, tizanidine is a newer skeletal muscle drug, and it is a congener of clonidine. So it is, we can say it is an analog of clonidine, and it is a newer approach for skeletal muscle relaxation. So it is a central alpha-2 receptor agonist. So here if the acetylcholine or adrenaline, if it binds to the alpha-2 receptors which are present in the which binds to the alpha-2 receptors which are present in the central nervous system, then it leads to the increase in the muscular tone. Here, it leads to the increase in the muscular tone. So here, this tizanidine, it is a alpha-2 agonist, or it is an analog of clonidine, where it binds to the alpha-2 receptors, and thereby it will reduce the muscular tone, and it even inhibits the release of the excitatory amino acids. So amino acids which are responsible for the excitatory reaction, that can be inhibited by this drug, and it is effective, or it can be used in multiple sclerosis, and it is used in spinal injury and stroke, and it is well absorbed when given orally, and it is administered in the form of tablets at the dose of 2 to 4 mg. Let us see the uses of this centrally acting skeletal muscle relaxants. So they are used to treat acute muscle spasm, and they are used to treat neuralgia and torticollis. Torticollis is a contraction of the colon region of the intestine, and anxiety and tension, and they are used to relieve the spasm in the neurological disorders, tetanus, and in the electroconvulsive therapy, which is a therapy which is used to treat epilepsy, and it is used in orthopedic manipulations.